Okay, this is 2402 lecture, the first chapter that I'm lecturing on videos, which is the chapter covering the respiratory system, as you can see up there. So you guys have already had that respiratory system lab. It seems like forever ago. It was the week before the break, and the long break. And you have your book. Stay there, I'll be right back. You have your book that has lots of respiratory system structures and little places to fill in stuff, and a few pages, page after page, really kind of a few. You still have to know that, but I'm not going to cover that stuff again. So this gross anatomical stuff right here, where you've got the cavities and the pharynx and the larynx and the trachea and all that stuff, learn that stuff again, or transpose that stuff into lecture, because the tissues and all that stuff you have to know. Lungs as well, diaphragm, etc. So when we get down here to the microscopic level, now we're looking at tiny little bronchioles that are terminal when they're reaching the end of their line, and respiratory, remember that? That means that they can actually exchange gases. And then you've got these alveolar sacs and alveoli, which are the individual things. And that's the business end of the respiratory system, surrounded by capillary beds. That's been taught. So refresh your memory on that, please. One thing I didn't talk specifically about in lab, which here it is over here. If you ran, swing into it, I probably could have gotten an image for this, but I'd already made this drawing. So there's a conducting zone, which is this. It conducts the air. So this is going to take the air from the outside down into the lungs, and as soon as you're able to exchange gases with the blood, you've left the conducting zone and you've entered the respiratory zone. So the respiratory zone consists of your respiratory bronchioles and your alveoli. The conducting zone is everything upstream of that. All right? And let's go back over to this to the monitor again. If you remember, we talked about the difference between the pressures in the pleural cavity versus the intrapulmonary cavity and the atmospheric pressure. Well, I'm just recapping, with your throat open, with your glottis open, you're going to have an equalization of pressure out here. The atmospheric pressure and the intrapulmonary pressure are going to be the same, which is average around 760 millimeters of mercury pressure. Now the intrapleural pressure in this pleural cavity here, filled with fluid, is less. It's 756, so on average about 4 millimeters of mercury less than the atmospheric pressure, less than your intrapulmonary pressure. So the effect that has is that it causes the air in your lungs to push against the wall of that pleural cavity there. So it keeps your lungs expanded. If this pressure went up, let's say you got an infection in here, or you've got fluid accumulation, or you've got an injury from the outside, then that's going to cause that pressure to equalize or be greater than the intrapulmonary pressure, and that'll cause a lung collapse, or at very least a reduction of surface area inside the lung. So that's why that happens. Remember, we have a negative pressure inspiration system where you actively contract muscles, and you do need to remember those muscles, the intercostals, diaphragm, abdominal muscles, shoulder muscles that are involved. And lastly, recap stuff is are these respiratory volumes and capacities. Here's a nice little graph that's probably nicer than the one in your lab book, but in any case, these volumes you have to know. 1, 2, 3, 4. You don't have to know these. Forget these two, just for whatever reason. TMI, I guess. And then vital capacity you have to know. Total lung capacity you have to know. They're also giving you some nice average numbers for your average adult male, which are something that you need to know for lab additionally. I'm going to go down here to this next part of this graph, where we can see these volumes again, and then some little descriptive information about them. They give the average female volumes as well, but you don't have to double know those, just know first column. And then this tells you what these guys are, they call them capacities because they're sums of volumes, right? So this tells you what add up to make them. But you could have basically determined that with this graph as well, because you can see the color patterns here that go into that capacity. All right, now I'm going to be moving on to new material, and the new material is not so graphically interesting. It's stuff I wrote, and it's over here, and then I'll talk about it. First, you remember we had 4 steps of respiration. We have pulmonary ventilation, which is, right, you breathe in and out. That's inspiration, expiration. We've got external respiration, which is gas exchange from the alveoli into the capillaries of the lungs. That's called external. We've got gas transport. I don't know if that one was explicitly stated, but you have to transport the gases from the lungs to the whatever tissues you're getting them to. Internal respiration, which is, and I've got them listed here, you'll see these terms again. Internal respiration, which is gas exchange at the capillaries of, say, the leg muscles or the abdominal organs or whatever. And then lastly is cellular respiration, which we're not going to get into any detail here in this chapter at all. So let's talk about first factors affecting. It's affecting. I'll put a little parenthesis, a little quote up there. So affecting ventilation. So this is pulmonary ventilation, moving the air in and out of your lungs. First off, you have airway resistance, and if you remember when we were in the blood vessel chapter, I talked about resistance, where flow equals change in pressure over resistance, right? So resistance is that big R denominator. And I've lost my spot. Where is it? This is terrible television. So flow equals delta P, delta P over resistance. Well, in this case, we're not going to care so much about resistance because it's air and it's got really low viscosity. So it's not as strong of a factor as it was moving a fluid, like a fairly viscous fluid like blood through blood vessels. So resistance is fairly negligible, and as long as you've got a functioning respiratory system, something we'll talk about at the end of this chapter, you're doing fine. So in a healthy person with normal functioning lungs, I can blow that air in and out well fast enough to supply. As soon as I say it, I have to cough. Alveolar surface tension. If you remember, the alveoli have their little sacs, and they've got a certain desire to shrink back like a balloon, right? So surface tension is important. But you have, luckily, those type 2 cells, if you remember those guys, those type 2 cells produce surfactant, which is a surface tension reducer. And you can get more surfactant secreted by those cells by taking deep breaths, so which is pretty cool. So if you're going to go for a run or you want to breathe easier, take some really deep breaths, like really exaggerate that. Those cells will secrete extra surfactant, and your subsequent breaths will even be easier. So, just a little helpful hint. Don't do it a bunch because you'll get lightheaded. And then lastly is your lung or thoracic cavity compliance. So compliance is going along with something, basically, right? In this case, compliance means going along with being stretched. So how stretchy or how flexible your thoracic cage and your lungs are. And for the most part, again, in a healthy person, that's going to be okay. Your alveoli aren't resisting, your intercostal muscles are fine, your diaphragm should be doing its job and inflating. So as long as you're functioning normally, that should work. Now, if you get injured or you've got scar tissue or fibers that are replacing muscle, it's going to be harder to do that. Or if you've got a chronic obstructive pulmonary disorder. So if you've got some kind of emphysema or something, which is going to go along with loss of surface area on the inside, decrease in thoracic cage and lung compliance, then you're going to have some troubles breathing. But in any case, if you're doing fine right now, you don't have any problems with any of these. But these are the things that can come into play. Except even airway resistance. If you've got reduced diameter of your bronchioles and things, you can get some resistance just because of the radius of the tube. This right here I'm going to mention later. Okay, I did throw in Boyle's law. You remember Boyle's law? P1 V1 equals P2 V2. Well, you have to know that one again. So that's how volume affects pressure and vice versa. There are some other laws and effects here which I will get to as I get to them. The first one, may as well get to right here. So now we're talking about factors affecting external respiration. So we've inhaled and exhaled, or inspired or expired. We brought in our air and gotten rid of it. We have to get it across that alveolar membrane into the blood vessels. So there's going to be a few things that I've jotted down here that can affect that. PP, or partial pressure gradients. So partial pressures are in air, let's say. Air's got nitrogen and oxygen and CO2 and some other real minor gases. There's more nitrogen than oxygen by far. There's like 80% or 79% nitrogen. There's only like 19% oxygen. So the partial pressure of nitrogen is greater because there's so much more of it. Now, all things being equal, that means you're going to absorb more nitrogen into your blood than you do oxygen. And as a matter of fact, you do have quite a bit of nitrogen dissolved in your blood. A fun fact, a not so fun fact here would be that this is what causes the bends or decompression syndrome. If you've ever gone diving or seen movies about people diving, sometimes they'll come up too fast and they'll go, ah, you know, and they'll start contorting. Because what happens is, just like if you open up a Coke bottle, that pressure is going to decrease in that Coke bottle, and any gases that are dissolved in that Coke immediately come out of solution and become air. So when you're breathing air real deep in the ocean and you surface too fast, the nitrogen that's been dissolved in your blood comes out of solution too fast, forming bubbles, like sort of cavitating inside of your bloodstream and rupturing blood vessels. And apparently is horribly painful and can kill you if you do enough of it. Don't worry about that around here, but just know that gases go into your blood based on how their frequency, their percentage in blood. This brings me to my first law, Dalton's law of partial pressures, which is basically, telling you what I just said. That is that the total pressure is the sum of all the pressures, and that leads to Henry's law, which is that gases dissolve in a liquid in proportion to their partial pressures. So the more of a gas you have, the more pressure it exerts on the walls. So nitrogen exerts the most pressure, oxygen exerts the next most, and that's Dalton's law. Henry's law then says that as a result of Dalton's law, these guys will dissolve in proportion to their partial pressures. So more nitrogen than oxygen, more oxygen than CO2, etc. Again, that's all else being equal. Now we go back over here to gas solubilities, and this is the thing I kind of just said all else being equal about. If nitrogen and oxygen and carbon dioxide all function exactly the same, they dissolve equally, then you could just base their absorption on those two laws. But they don't. You don't have to know which one's more soluble than the other. They're all pretty soluble. Good thing oxygen is, because that's the one we want. Nitrogen is too, but it doesn't hurt us. Ventilation and perfusion coupling. This is a complicated sounding thing, but it's not if you just break down the words. So ventilation is the thing we just talked about, pulmonary ventilation. So that's that. So I'm going to couple that with perfusion, which is getting that gas into my blood. So if I've got I think I mentioned this, I think we talked about this in the blood vessel section, but if I've got two alveoli, so let's say I've got two alveolar sacs, right? Here's one, and here's one. And this one has a blockage of the bronchiole, or it's got some mucus built up on the inside, or whatever, okay? It's got some occlusion of some sort. This one is just doing great, right? Right, he's happy. So the one on the right here in this case, this smiley face one, is going to have a lot more air in it, and it's going to have therefore a lot more oxygen in it. So what you're going to do in this case as a result is you're going to send more blood to here. This is a capillary, right? So you're going to send a greater amount of blood to the capillaries that supply the good one, and a lesser amount of blood to this one. So less, I don't know what I'm trying to write there. More blood to the one that's giving you the best supply, less blood to the one that's giving you the least supply, which is what perfusion is. So perfusion of blood in this case is how much blood you can put in that area and how much gas you can get into that blood. So you want to max out the good ones, not so much for the poor ones. And then lastly is the thickness of the respiratory membrane. It's a good thing that in a healthy individual you don't have a problem with that. The membrane is very thin. It's between 0.5 and 1 millimeters thickness total. That's the alveolar membrane and the capillary endothelium and any stuff that's in between. And that's a fairly small thickness. And it's also very big. It's not thin and big. It's thin in cross section, but huge in total surface area. So you've got, in an average person, somewhere around 90 square meters of lung space. If I took my lungs out and unfolded them down to the alveolus, and I laid them all out on the ground, they would cover approximately like a tennis court. So, and I don't play tennis, so I don't know how big that is, but it looks pretty big in my mind. So, you could play tennis. You could play tennis on your lungs if you opened them up. Except for you'd wreck the court immediately. That's good enough for our external respiration. So that's just getting the gases into the blood. And I'll touch back on it in a minute, but we'll move to the next thing. And this one's really short. Look, internal respiration. What factors drive internal respiration? It's basically 1 and 2 from above. So partial pressure gradients and gas solubilities. This doesn't count because you're not ventilating in your leg muscles, and the membrane is still very thin, but you don't have lungs in your legs. So, excuse me. Similar factors drive how the gas gets from your capillaries to your muscle cells or to your liver cells or to wherever. So that's, if you just want to remember back, this is getting the gas into your blood from your lungs. This is getting the gas out of your blood into your muscles and all the other types of tissues. I'm going to move over to the next column here and try and figure out where I'm at. I'm past that. And I'm past that. And past that. Oh, here I am. Okay, I see where I'm at. So now we're talking about gas transport. So these last two columns here, this one and that one, deal with oxygen. You'll see the second one maybe in a minute. This one deals with oxygen transport specifically. All right? Well, oxygen can dissolve in a liquid. You can dissolve oxygen in water. That's how fish breathe. You can dissolve oxygen in other solutions, other liquids. But it's better dissolved in something that's specifically attracted to it. So we have a molecule in our blood cells called hemoglobin. And hemoglobin is a 4-part protein that has a little heme unit at each center of each one. So hemoglobin molecules can carry 4 oxygens each. That's just a number I'm going to throw out there because it'll mean something in a minute. You carry about 98.5% of our oxygen attached to these hemoglobin molecules. And it's because the hemoglobin really has an affinity, A-F-F-I-N-I-T-Y, affinity, an attraction to oxygen molecules. The other 1.5% you carry in just dissolved in your plasma like you would in water. Okay, now this next little deal here, I've seen it throw students because it gets a little confusing, but it's really straightforward. Let's see if maybe it's my delivery. If I can carry, let's say if I've got a hemoglobin molecule right here, and I've got it drawn in 4 bits because, like I said, it's got 4 polypeptide subgroups. So I'm going to carry oxygen. I can carry an oxygen here, 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 and here. Right? So right now, hemoglobin, it likes oxygen. It really, if you show it some oxygen, it's going to be like, yeah, give me some. Right? So if I have a hemoglobin molecule floating through my capillaries in my lungs, and I take a breath, and an oxygen molecule comes along, it's going to go, whoop, and it's going to get sucked onto there. And this has kind of the effect of whetting the hemoglobin's appetite for more oxygen. So when it picks up one oxygen, it gets a little bit greedier. So it's going to have a little bit stronger attraction for the next oxygen. So the next oxygen that comes by, whoop, which is going to increase its affinity for oxygen even more, and then whoop, and whoop. So it really gets greedy. So the rich get richer, right? So as that guy collects oxygens, it really wants them a lot more. Well, why is that a good thing? Because if you picture, if I take a breath, and I'm not going to breathe normally here, but I'm going to take a breath and hold it. So, all right, so I'm done with that. What happened there is that I filled my lungs up with a small amount of air, and as I sat there, the oxygen in that air volume in my lungs was being depleted as it went into the blood, right? So, hold on. I have to take a big breath. I kind of held it there. So what happens is that as I hold my breath and oxygen becomes more scarce proportionally in my lungs, the hemoglobin that's coming through can still grab it because it's like, I'll still take that even if it's at a low pressure, all right? This allows you to hold your breath underwater, and if you need to, for longer than you would if it wasn't able to do that. Turns out that when hemoglobin leaves your blood, and when blood cells themselves leave your blood, they're basically, as long as you've been breathing normally, they're basically got 100% saturation. So what that means is that the hemoglobins in all of the blood cells that leave the capillary beds of your lungs are full of oxygen. Now I'm going to send those out to my tissues, and I'm going to drop them off. So I'm going to send them out to my arm muscle, right? What little there is. So the arm muscle's contracting, and it needs oxygen. That arm muscle starts sucking oxygen from the hemoglobin and from the red blood cells, but it says that by the time it leaves, by the time it leaves the tissues, it's down to about 75% saturation. So what that means is you've lost one oxygen per hemoglobin. Well, that doesn't seem very efficient. If I'm going to drive a truck full of stuff to a place and drop off some stuff, I'm not going to drop off a quarter of it and go back to the place that I got whatever that's wood or whatever from, add another quarter of wood and then drive back. But that's kind of what hemoglobin does. But we don't like empty dump trucks with no oxygen. So let's just say I did go underneath the water and I was holding my breath. If those things dumped off that oxygen, and depleted themselves, they would be, they don't have any sort of backup. There's no wiggle room there. This also works for places where you have oxygen stress. So if you're doing if you're exercising really strenuously, you can drop off some more. Or if you're go to a high elevation, if you go skiing or something in the mountains, you're going to have that sort of reserve of oxygen content. If you don't get enough oxygen to your tissues, you experience what's called hypoxia. So there's a whole range of hypoxias. I'm not going to go into them, but I do want to make a call back to one of these laws or effects over here because of the oxygen discussion, and that's coming back to the Bohr effect, which insert joke there. But this has to do with the affinity for oxygen in your tissues. And let me describe the conditions necessary to experience the Bohr effect. Probably these conditions there, I inserted the joke. Bohr effect, I'm just going to kind of add in here. High temperatures, high partial pressure of carbon dioxide, and I'll say high, I should have used my arrows, high hydrogen ion concentration, so acidic. So these conditions right here are most conducive to unloading oxygen. Well, where do I find high temperatures, high carbon dioxide concentration in the tissues, and high hydrogen ion concentrations or acidic solutions? I find those in my deep muscle tissues, anywhere that's been doing a lot. If I'm going to do some squats or whatever, I'm going to build up temperature in there. Those muscles are going to be releasing a lot of CO2, and they're going to actually, as a result, cause the plasma and the cytoplasm to become acidic. So if your muscles are hot, have a lot of CO2, and are acidic, what that tells you is that you are increasing the likelihood of offloading oxygen. So the Bohr effect is when you offload oxygen in the muscles. That's just an example. Under these conditions, and I'm sorry about the kind of disorganized manner of that presentation. Maybe that's why it's confusing. But hopefully that's the Bohr effect. Bohr effect deals with oxygen, and it says oxygen doesn't want to hang out with hemoglobin when it's hot, acidic, and carbon dioxide-y. Perfect conditions for when you're doing exercise. All right, now let's go back over here to this column. The last one. Can you see it? Am I in frame? How about now? All right, so this last column has to do with carbon dioxide transport. This is critical as well. We're picking up oxygen in the lungs, bringing it down to our body tissues, dropping it off. And then on the return trip, when I was a roofer, side story. When I was a roofer after high school and for the first couple of years of college, if I had to go down to the ground to do anything, use the restroom, drink some water, whatever it was, if I tried to come up the ladder again without a bundle of shingles, the boss would yell at me and make me go back down the ladder and get the bundle of shingles. So there's no such thing as a wasted trip. If you're going down the ladder, bring some garbage. If you're coming up the ladder, bring some shingles, right? So these are the shingles. On my way back up the ladder, going back up to the lungs, I need to bring some garbage. So we need to get rid of this CO2. And if you remember that cellular respiration, which you don't have to in detail, basically releases CO2 from the sugar molecules being burned and uses up oxygen at the very last step of the electron transport chain. So basically catching electrons. So that CO2 now is a waste product. You don't want it, you got to get rid of it, and you've got to carry it back to your lungs so you can exhale it. And that is the job mostly of a little buffer molecule in your blood called bicarbonate. So bicarbonate's able to just grab carbons, right? Grab carbon dioxides. And it does so, as it turns out, it does so, and I'll show you based on the next and last effect, the Haldane effect. So under those high temperatures and acidic conditions where there's high CO2 pressure, you're really going to start absorbing those CO2s. Most of it by bicarbonate, some of it's carried in your hemoglobin. Now, it's not carried by the same thing, the heme group, as oxygen is carried, but it's carried instead by some of the amino acids. So they call it carbaminohemoglobin when it is carrying carbon dioxide. And then 10%, the last tenth of it, is just dissolved in your plasma. CO2 can dissolve in plasma, just like it can dissolve in Coke. Yeah, so now let's go back over here again. Back over to these effects. And I always got to double check my notes on these. I'm just like you, I can forget stuff. So the last effect, the Haldane effect, involves carbon dioxide affinity. And this is where I was looking at the wrong column there. So low carbon dioxide, partial pressure in the tissues, or I'll say in the lungs, I'll just say that, increases blood offload of CO2. So in the lungs, where you've got cooler temperatures than your deep muscle tissue, you've got fresh air being inhaled, so you've got high oxygen, low CO2, and they're not very acidic up there in the lungs. This greatly increases your blood's desire to ditch the carbon dioxide that it picked up. So if you look at these two effects, if you look at the Bohr effect and the Haldane effect, the conditions in the lung are very conducive to picking up oxygen and dropping off carbon dioxide. And then when that blood goes down to my legs, it's full of oxygen, but it finds itself in a place where you have high temperatures, high CO2, and high low acidity, acidic conditions, I should say. That is going to cause the oxygen to want to get out of the blood, so offload it. At the same time, you're picking up CO2. So when you go down, you drop off oxygen, pick up CO2. When you go back to the lungs, you pick up oxygen and drop off CO2. So you may say, wow, what a coincidence that those two conditions are such that they're both helpful for the jobs that they need to do at that spot. But that's not the case at all. That's how evolution works. So evolution works to kind of fine-tune molecules to act in hopefully a nearly optimal manner. Doesn't always optimize everything, doesn't even try to optimize anything. It's just that the results of evolution cause the formation of molecules that just seem to happen to work really well in their given conditions. And I'm going to take a short break. Am I on? Oh, I'm on. Oh. All right, so I should have basically finished this, but I was getting thirsty and I didn't know exactly where I was going next. It's probably good to have it written up here. So, second thought, I shouldn't have finished it. So now I'm going to finish up this chapter, respiration still, with some larger factors that control it, and then some disorders that you can have with it. So first of all, how inside of us, how do we decide when we want to breathe? You may say, well, I just breathe when I breathe, but internally there's some chemical conditions that are going on that are going to influence that. And those are picked up in your brain. So you've got in the medulla and the pons, primarily, these two regions are going to generate impulses, which will then stimulate your your external intercostals to inhale and your diaphragm to inhale. They send impulses down the phrenic nerve and the intercostal nerves, which stimulate the diaphragm and the intercostal muscles respectively. So the phrenic stimulates diaphragm and the intercostal stimulates the intercostals. And that's going to be at a rate which is determined by the next thing that I'm going to talk about. So active inspiration, and usually you're not like, you know what I mean? You're not doing that. You're just breathing normally. And if you had somebody else time your breathing, you'd find that you probably breathe between 12 and 15 times a minute, which is, every time I even say that number, it feels like low to me. I feel like it should, I guess, probably 30 times a minute, but no. But once you start paying attention to it, you change its behavior, right? So if you ever just want to creep on somebody and time their breathing, that would be a good scientific experiment, also a good way to get a restraining order. But in any case, normal breathing, 12 to 15 times a minute, is called eupnea. So if you're exhibiting eupnea, you're exhibiting normal breathing. Just gotta catch up. No, I'm probably a lot wider shot than I think. All right, so now here's the things that your brain picks up on to cause you to breathe. The most important one, surprisingly to a lot of people, is carbon dioxide. So you'd think it would be oxygen, right? Because you'd think oxygen, I need that, so if it starts getting low, I might want to take a breath. Well, it turns out that if you hold your breath, oxygen depletes and CO2 builds up, which they both go hand in hand, basically. So this one just happens to have the more sensitive receptors. So the CO2 receptors respond to an increase in arterial CO2 levels by telling your brain to send the impulses more rapidly. So if you've ever taken a deep breath and held it for a minute like I did a while back and then breathe out, my CO2 levels are pretty high. So I'm gonna take a couple rapid breaths. It works just fine 99% of the time. The only times it doesn't work fine, and this is kind of just a sad fun fact, is when somebody's breathing normally, when they're normally ventilating, when they're pushing air in and out of their lungs, but they're not getting any new oxygen in. So you're breathing, there's a recent case of a couple of kids dying from helium inhalation. So you're sitting in there in this helium room for whatever reason, talking funny, right? Ha ha, it's funny. But you're breathing helium, but every time you breathe out, you're dumping the CO2. So your blood CO2 levels never rise because you're constantly exhaling. But because you're breathing in helium, you're not getting the oxygen you need. So your body runs out of, you lose consciousness before your body sends out the alarm that you're not getting any oxygen. So those oxygen sensors are actually kind of low. This also works for when people kill themselves with carbon monoxide and stuff, but in any case, a little morose term. So you will respond to oxygen levels being too low by increasing your respiration rate as well. This is more probably important if you go up on a mountain where you just have low oxygen. And a very low pH, acidic conditions. Low pHs are caused by lots of CO2, so these guys go hand in hand. Low pHs lead to an increase in respiration rate. So you guys remember my little schematic here, right? High CO2 leads to high respiration rate. Low O2 leads to blah, blah. All right. Your cerebrum, that's your cerebral cortex, that big thinky bit on top of your head there, and your hypothalamus, which is the part right in back, also influence respiration. The hypothalamus is really important in responding to these things. If you're relaxed, you're just mellowing out, you're listening to some music, and you don't have any worries, like everybody today, no worries. You're going to breathe slowly. If you're amped up or nervous or panicky about something, you're going to breathe more rapidly. If you've ever been stressed and trying to go to sleep, you'll notice that your heart's beating harder and your breath is coming faster. Pain will cause you to increase the respiration rate and blood pressure for that matter. And that's kind of that whole sympathetic nervous system response of fight or flight. And then body temperature. Higher temperature leads to increased respiration. Cerebrum's involved in kind of a way that you wouldn't think of it. And that is, if you've ever seen like a kid hold his breath, I'm gonna hold my breath because I don't want to eat my broccoli, right? And if the parent goes, oh no, here you can have cake instead. Well, they're making a mistake. And I'm not telling you how to raise your kids, but the kid's cerebrum's gonna tell him to like stop being an idiot before he really endangers himself. Worst comes to worst, he passes out for a couple seconds, and then his normal respiration rate reoccurs, and the broccoli's still there. So good. That's a good suggestion. Pulmonary irritants. If you get something in your nose or your lungs, if you ever inhaled a bug or whatever, or a piece of grass or something, you're like, right? You immediately just start spastically coughing. That's a way to expel that irritant. And a sneeze is like if you get a tickle up there in your nasal cavities. So those cause an involuntary expiration. Exercise, didn't write anything down there because if you're working out, you're breathing faster. Altitude, altitude's got a couple of interesting characteristics. If you go to a higher altitude, you will, so if let's say I go to Vail and I want to go skiing, when I arrive, my respiration rate's going to tick up because there's lower partial pressure of oxygen, lower pressure in general of oxygen in the air. And so I'm going to need to breathe deeper and more frequently to make up for that deficit. But if I live in Vail for a few months, my body's going to kind of adapt to that. So it's going to kind of restabilize at my normal respiration rate. So I may go up for a while, may go up above 12 or 15 breaths per minute for a given amount of time, I don't know it. But then after acclimating, you get more blood cells and you get more efficiency, more blood vessels. You're going to just return back to that normal human rate. Let's go over to the next panel. Okay, disorders. I've got a bunch that you've all heard of and then one that you've really heard of recently. So bronchitis is, any itis is inflammation. So bronchitis is inflammation of the bronchi. And we've all probably had bronchitis before. Your breath doesn't feel as easy. You may have a little bit of wheezing or rattling in your breath, but it's probably, you may not need to be even treated with it, but it's usually a bacterial, could be viral. But most cases of bronchitis, just generic bronchitis, are common and easily defeated by your immune systems. Asthma is going to be an overproduction of like mucus and constriction of the bronchioles. Some people have really chronic asthma, and they have to treat that with inhalers and steroids and so on. Shifting gears here, cancer. So this is a specific lung cancer, so specific cancer forming in the epithelial tissue of the lungs. Most of it, 9 out of 10 times, it's going to be directly or indirectly due to smoking. So if you're watching this video and you're a smoker, I'm sure you've heard it all before. I'm probably not going to change your mind, but Plus, you can't hardly walk up the stairs. Just, stop. So, I can't, it's easy for me to say, right? Okay, sorry. Tuberculosis. This is a bacterial infection of the lungs, which you have to get tested for these days, right? It used to be a big killer of people. If you've ever seen Tombstone, or you know who Doc Holliday is, he had tuberculosis. By the way, you should watch that movie. It's a really good movie. Val Kilmer does a great job as Doc Holliday. It's a bacterial infection. There's little clumps, little like bumps in the lungs called tubercles, which form as your body tries to encapsulate the bacterial colonies. But usually it doesn't work, and you just end up coughing it up, and you start coughing up blood and spittle, and that's largely how it spreads. And lastly, and topically, is COVID-19, right? So there's several different names for the disease. I guess the technically official name for it is COVID-19, which means coronavirus December 19, right? But that's the name of the disease. The official name of the virus now is SARS, Severe Acute Respiratory Syndrome Coronavirus 2, because if you're old enough to remember a SARS, infection epidemic in like 2004, I can't remember when it was, early 2000s, that was spreading through China again, but it managed to get contained. Still unknown reasons, right? But it was a dangerous, frightening, viral disease that went from animals to humans, and with a combination of containment and care and prevention, it was largely eradicated. It basically disappeared. Now, this new coronavirus they call it coronavirus 2, or SARS-2, or whatever. This is a new coronavirus, and a coronavirus is just a class of virus. It's not a flu, neither was the other one. These are not flus, okay? You probably heard that already, but they're not influenza. Right now, the mortality rate is at least 10 times, if not more, greater than a flu, and it seems to be more contagious. So bad and bad, right? However, having said that, currently about 80% of the people who get it recover without treatment. So you may notice it, you may not notice it. There's people that test positive for the virus that don't notice any symptoms. But even if you notice symptoms, 80% of all people recover without even going to the doctor. So that's what that means, right? Now, they can classify these sicknesses in 4 separate large categories. Subclinical, you don't notice anything. So you're going to be either asymptomatic, or you won't associate it with anything. You just feel like, I feel a little bloopy today, right? Second category, upper respiratory tract infection with cough and a light fever. We've all had mild flu-like symptoms before, and I don't, again, want to conflate flu and this thing. It's a completely different class of virus. But similar types of symptoms resulting from different types of viruses. So this is the kind of thing that heretofore we would usually fight through and go to class, go to school, right? Or go to work. So if you had this a month ago or 2 months ago or a year ago, you'd be like, I can make it, right? You'd go there and you'd try to, I don't feel great, or cover your cough or whatever. But you can get those symptoms from coronavirus as well. The third category, where you get severe flu-like symptoms, and these keep you from work. Now we know, right? Now, like maybe a month ago or 2 months ago, you would be like, I better stay home for sure. But you wouldn't necessarily associate it with coronavirus, because it was being underestimated, I believe is the word that I want there. But now you know, and if you get these symptoms, please, for sure, don't get near anybody. And then the last and most serious would be a serious deep respiratory tract infection, which includes pneumonia. And pneumonia is like accumulation of fluid and basically filling of the lungs with stuff that's not air. So when you fill your lungs with non-air, you can't get oxygen and you die, you suffocate. So hopefully this isn't a video that some future people find on, and go, well, he said it, hopefully we'll get out of this. But humans have been through some bad stuff, so we got a fighter's chance. But in any case, that's like your brief synopsis of coronavirus. That's it for chapter Respiratory System, which is, and I'm going to get, you can stay there, I'll be right back, which is, sorry, dead air, chapter 23, and it's also the first chapter of Unit 3. So some of you have had test 1 and 2. One of my sections has only had test 1, and I'm making test 2 to deploy online. Respiratory system is the beginning of the stuff for test 3, which is going to include respiratory, digestive, and nutrition and metabolism. Cool, thanks. These should be uploaded soon. Actually, if you're looking at them, they are.